Welcome to Be Empowered, the podcast. This is a podcast where we dive into the realities of healthcare and entrepreneurship. We offer our opinion, unfiltered, unapologetic, and always with a dose of empowerment. We're here to amplify voices, both yours and ours, challenge the status quo, and explore what it really means to thrive. So let's get into it. I'm Dr. Santoshi Bilakota,
And I'm Dr. Shana Morfel.
and today we have a very special guest with us. We have Simran Grewal, who's a heart transplant nurse practitioner, and she's here to talk to us a little bit about what being a nurse practitioner is like in the current healthcare system, how she got into it, and how she manages her work life balance. So, Simran, go ahead if you don't mind giving a brief introduction of yourself.
Hi, everyone, and thank you for having me on this podcast. My name is Simran Grewal. I'm one of the nurse practitioners in the heart transplant field. I've been a nurse for about 14 years as of 2025, and I have primarily worked in the cardiology heart failure field. Initially, I started as a floor nurse practitioner on one of the cardiology floors where we got a ton of post-procedure patients and moved to the ICU, and I worked in the cardiothoracic ICU for about 2 to 3 years, and then went ahead and pursued my career as a nurse practitioner, and I've been in my role as a nurse practitioner for advanced heart failure in the last 8 years or so.
That's great. So, what are the common misconceptions about NPs, and what do you wish more physicians understand about your role as a nurse practitioner?
Yeah. So I think one of the biggest misconceptions that I've come across is that nurse practitioners cannot practice independently or are not autonomous. My current practice is all of my visits are independent visits, which means that I do have an MD available for consultation should I see a very complex or challenging case. But most of the decisions, most of the diagnoses, orders, tests, and medication changes that I do are independent practice. And I don't need consultation from the physicians as long as I have the appropriate training in that particular field. So I think some of the things that's a misconception is a lot of times my patients will ask, not a lot, but sometimes my patients will ask me, oh, do you need to run this plan with the doctor? And I would say, no, I'm very confident in the plan I made for you. And of course, if this is a complex plan, then I would run it with the attending for that patient. But otherwise, we like to practice independently. And I think one of the things that I wish the physicians understand a little bit about our role is that we come from a ton of experience, including nursing experience, and we try to incorporate that into our practice. So we like to advocate more for our patients and look at the overall picture rather than everything being just black and white, rather than just having a patient come with a diagnosis and just treat it. You also want to incorporate the patient's emotions, their mental health, their overall well-being into caring for the patient. So I wish the physicians sort of looked at it a little bit more that way too.
How do you see the physicians helping you in that independence?
So I think when I started, and I've been practicing at 2 different institutions for the last 8 years, and what helped me a lot is beginning orientation with the attending physicians. I think the disadvantage of being a nurse practitioner is you don't get to go to medical school and you don't get a ton of radiology training or echo reading training or things like that. So I think shadowing the attendings who've been doing this for several years and learning on a case-by-case basis how to read echoes, how to interpret stress tests, how to sort of manage patients on more of a medical basis, in addition to what we do helped a lot, and collaborating with physicians that way helps a lot in our day-to-day routine for nurse practitioners.
Yeah, so I practice in New York City, and so I've worked with a lot of nurse practitioners. It's very common here, and there's some really, really good nurse practitioners, especially in subspecialties. How
Mhm.
long did it take you to kind of feel comfortable? Because transplant, has to be very challenging. I couldn't do it, but I'm sure it was like a learning curve for you to get to a point where you're like, yes, I can do this autonomously now.
Yeah, definitely. I mean, it took a couple of years for me to be fully independent and sort of believe in my decisions. What really helped me is I knew from the beginning that I wanted to pursue something in cardiology. So when I was
Mhm.
in NP school at UCLA, I requested primarily all cardiology rotations. So I was able to get an advanced heart failure rotation at Cedars-Sinai, as well as a cardiothoracic surgery rotation. And I got in to see a couple of heart transplant surgeries in person. I got to go harvest the heart in a helicopter from Cedars. So a lot of my in-school training was focused on advanced heart failure and transplant. And luckily, right after that, I was able to, as a new grad, secure a job in the advanced heart failure setting as well. So that helped build a foundation that was already strong from the beginning to help care for these patients. And I've sort of advanced myself in that particular subspecialty, ignoring all the other specialties and kind of focusing primarily on cardiology, transplant, and advanced heart failure. And I think having a very strong mentor, an NP mentor, helps a lot too in that.
So, how do you feel about increasing independence of NPs in some other states, especially new grads?
I have mixed feelings about that. I feel that it's great that NPs are getting more independence, but it should be based on their prior experience. There are a ton of programs in schools these days that are offering NP programs to new nurses, which means that you come in, you become a nurse, a bedside nurse, and right away get an NP degree, and then those nurse practitioners are then released into the field to work independently, which can be very challenging. I think the biggest thing that helped me is the 5 years of bedside nursing background that I had, both on the floor and the ICU, because that led to a strong foundation of working independently as a nurse practitioner. And the school that I went to, UCLA, required that whoever applied to the program have at least 3 to 5 years of acute care nursing experience to be able to function as an acute care nurse practitioner. So I am seeing a ton of new grad nurse practitioners. I'm precepting a few at the moment, and I do see the challenges of never having worked as a nurse on the floor and now suddenly having to diagnose and treat and triage very complex patients in the hospital. So I think there needs to be some sort of what's the right word I'm looking for? Regulation around that for someone who would be working independently as a mid-level provider.
Yeah, I think when it comes to a lot of MDs, I think a lot of thoughts. I mean, there's a lot of doctors who have a lot of thoughts on the new
Mhm.
grads who are coming out straight from school with no clinical experience and going into independent practice. I think your situation is very different. You went. I'm also a UCLA grad, but you
Good,
went to a
awesome.
really top school that takes education seriously, and it sounds like
Mhm.
there's you went through a lot of training, a lot of bedside experience, which I think a lot of people, um well, I won't say a lot of people, but I think little minority that I'm seeing online talking about this and all that, they are advocating for NPs to maybe skip that bedside nursing part, which to me feels like that's where you get most of your education in terms of physiology, in terms of how to deal with patients. So I don't think that should be skipped over, but
Mhm.
lately it seems like there's a lot of degree mills that are developing where they're promising all these dreams to new grad NPs. How do you find that to be sustainable, or do you think at some point that's going to kind of blow up?
Yeah, I think it's not the greatest idea to release brand new nurse
Yeah.
practitioners onto the field, and it also depends on the training that you get and the subspecialty that you're in. I'm seeing a mix of family nurse practitioners who are being hired for the acute care roles, or primary nurse practitioners again being hired for the acute care roles. So I think if you did undergo training for primary care nurse practitioner, then you should appropriately be hired in that setting. If you, let's say, trained in outpatient clinics and now you've been hired as a hospitalist nurse practitioner in the hospital, that experience is going to be very, very different for you. And I think as future nurse practitioners, they need to think about the liability of taking care of high risk patients when you have not been trained to do that. So getting the appropriate training and getting bedside experience should be encouraged a little bit more. A lot of my experience in cardiology came from running codes on the floor. When you didn't have a physician nearby, an ER doctor was not showing up, and you're coding a patient actively while waiting for a physician, or someone crashing in the ICU, you're putting them on ECMO and all these other things that you're learning about. That experience, that raw experience of just working as a bedside nurse, is so vital and important, that should not be taken away. And one of the biggest things that I learned as a bedside nurse that I still carry forward in my role as an NP is empathy, which when you go to school and you go straight into practice, you don't learn as much to empathize with patients and kind of deep dive into their overall well-being. And like I said earlier, their mental health. So I think that's very important that that nursing experience comes in handy at that
So
time.
that leads to the question of online NP programs. So what are your thoughts about those?
Yeah, I think, like I said earlier, I'm not the greatest fan of current NP programs that are going around. So what I have recommended to our current institution is that if we do hire a new grad, we at least give them 6 months of onboarding training, including didactics and just overall side-by-side training with a trained nurse practitioner, so that the new grads feel a little more confident in caring for the patients. And of course, there's always a physician, a supervising physician who's attached to the new grad nurse practitioner, or in general, every nurse practitioner. But there should be more one-on-one guidance for someone who's brand new. I see that the demand is high, which is why more new grads are being hired onto some very high-level complex roles, including cardiothoracic surgery, ICUs, which is challenging. But they just need a little bit more hand holding in the first few months to maybe the first year.
Yeah, definitely. I do think, there is a market for it. I work with some really good nurse practitioners, and I think there's definitely a role for nurse practitioners in medicine. The nurse practitioners I've worked with have been NPs for over a decade, and that's not even
Mhm.
counting the bedside nursing experience they had, to a point where I would be okay if they were independently practicing. But I think what also makes them a good nurse practitioner is when they're not sure, they will always refer back to the attending, which I think is important as well, because I do that myself. If I see something that I'm not sure, I'll ask a colleague for their opinion, and I think that kind of collaboration is very important. Um,
Yeah.
where do you see the future of nurse practitioner practices going? Do you think they'll be able to eventually take on more and more independent physician like roles, or do you feel like it'll just be an ongoing collaboration?
Yeah.
Kind of what direction would you give someone who is considering NP school today?
Yeah, I think I've seen tremendous growth in overall just the nurse practitioner field and as a profession in the last few years. When I initially started back in 2017 as an NP, there were only a handful of us at the institution that I worked at the time. And now it's expanded to maybe hundreds or to over up to 500 nurse practitioners solely for that institution. I think it's helpful because as a program or as an institution, you're able to see more patients. When you have nurse practitioners in your team or in your institution, you're able to reduce readmissions, you're able to improve patient outcomes. So overall, as a field, nurse practitioner jobs are growing a lot.
Hmm.
So I think the biggest advice would be, if you can get a couple of years of bedside nursing experience, that would be most valuable.
Hmm.
Going to a strong school with a very, very good program is ideal. I know during COVID, a lot of people went into online schools and tried to get the education that way. But now that we have the options to go back into school, just getting that one-on-one time with good clinical rotations, good clinical placements is very helpful. I do recall when I was at UCLA, one of the rotations I wanted was the cardiothoracic surgery rotation. And they said, you don't have ICU experience, so you can't do that. So I switched roles mid NP program and I became an ICU nurse from being a floor nurse, got my ICU experience and applied for the clinical rotation, and I was able to secure that. So having that motivation and sort of being clear on what you want when you're going into this field would be helpful. Of course, if you don't know which subspecialty you want to go into, kind of exploring different specialties during your NP school helps a lot to tailor what you would eventually want to do as a nurse practitioner.
That's great. What challenges do you think NPs face in today's healthcare system in terms of administrative burdens?
Oh, that's a big one. I think recently there's been a major push in increasing the RVUs for each nurse practitioner. Although what I see is that the RVUs that NPs are required to achieve or complete is not related to a direct compensation or increased compensation. So you've got a set salary or a set pay, but you're still required to meet certain level of RVUs. And I think sometimes that can compromise patient care because you're being asked, some of us are being asked to see 12 to 14 patients a day, but you have to remember that these patients are highly complex post-transplant, or in general, any acute care clinic will have very, very complex patients, and you don't want to ever have the patient feel that you don't have enough time for that. You don't want to be like, all right, bye, I gotta go. I've got the next patient in like 5 minutes. So whatever your concerns are, bring them back next time. No, you want to offer, support, offer to listen to their concerns and address as much as possible so that they don't go back feeling like their provider did not listen to them or did not address their concerns. So I think it's good to have some sort of a benchmark for what the nurse practitioners should do, but that should also be varied upon your individual practice. Like a post-surgery nurse practitioner can see 14 patients a day because all they have to look at is surgical issues and make sure that there's no infection. So back to back, you can just get those patients out. But for some of the complex, challenging fields such as heart and lung transplant, you really need more time with those patients. I mean, the medications they're on is average about 25 meds. So you have to go over everything and make sure they're doing okay and that their transplant's working. So yeah,
Transplant patients are very sick. I
yeah.
remember the few rotations that I did do in my intern year, and certainly it sounds like you guys are also facing the same push that we're facing on the physician end, like see more patients, generate more RVUs,
Hmm.
and that just cuts the time short for your visits, which I don't think is fair to the patients. And ultimately, the goal of this whole podcast was to also advocate for patients, because ultimately if the providers are kind of stuck between a rock and a hard place, the patient ends up suffering. So when you're dealing with those types of challenges where you're being asked to see more and more patients in less and less time, inevitably that leads to burnout. Do you feel like burnout is a major issue for you specifically, and if so, how do you personally manage it?
Yeah, I feel like in the recent times when there's not enough providers and patient volumes are increasing, burnout has been fairly noticed. And personally, for me, I have felt more burnout just from working. But one of the things that I always try to balance is I try to make sure that I never work past my hours. I've got two kids at home, and I want to make sure that I give as much time to them as possible and not be consumed by work all the time. So I do set expectations and limits with my staff. I work with a ton of nurses who need to review a lot of things with me during the day. And I do set a time limit of when I would be reachable for, and then after that, it would have to wait the next day, unless it's absolutely urgent or emergent, in which case the patient should present to the ER. There should be a discussion with the attending. So I think setting boundaries and setting limits will help to prevent burnout. Some of the other things that I actually enjoy in my work is doing research and being part of research studies. So I have asked for some time be taken out for admin time or for research time where I get to do things that are not so just seeing patients all day in clinic, but be able to do something that I thoroughly enjoy, like presenting at different conferences, submitting abstracts, and things like that. So luckily, I've been able to work with leadership to carve out some time to do those things. Which I think, if you find something that's joyful in your job, which still
Mhm.
pertains to your job, but something other than the monotony of seeing just patients, 10 to 12 patients a day, would be helpful. And I've been able to slowly find that in my role.
It's great to hear. Do you think the nurses union have been helpful in addressing some of those challenges, in getting appropriate pay and setting boundaries for the nurses?
Oh, definitely. Oh, definitely. Yeah, yeah. Where at work at the moment, our union is very strong. They've been able to get us amazing pay increases based on your experience, and if ever we feel that the ratios are being disrupted, as in if we're asked or required to see more patients, we can always bring up the issue to the union, and they're available all the time to address concerns with management. So yeah. I think that's another tip if we want to go back to what would I recommend for future nurse practitioners is maybe try to consider in your initial job an institution with a union because they're very, very protective of nurses and nurse practitioners.
100%. I think physicians should also, I mean, residents right now are also unionizing, which I think is so helpful for training purposes. Physicians as a whole don't generally unionize, but I do think that would be helpful moving
Yeah.
forward. I think how are you supposed to make systemic change unless you have the majority speaking out against certain things?
Yep.
Is there any specific things that you think need to be changed in terms of systemically for the healthcare system? Like, that's a huge question. I totally understand that. But what are like a few things that you've identified that you're like, okay, if this can be addended or amended a little bit, be it ratios, be it pay, be it time we're allowed to spend with patients, it might overall help the burden from our day to day tasks.
Yeah, I think the biggest one that I've noticed is the time that we're allowed to spend with our patients. The need to see increased number of patients has limited the time that I get to spend with each patient, and I thoroughly like going into detail and spending as much time as I can with each patient and address all their concerns. Which is why sometimes I ask them to come see me back in 1 to 2 weeks if things don't get addressed in the 30-minute slot that I'm given for each patient. But addressing all of their concerns and thoroughly going over everything would help reduce readmissions, which in general would help reduce patient mortality, which would help improve just overall outcomes for the institution as well as for the patient. So I think giving more time to your patients and focusing would be a big improvement if we're able to do that.
Thoughts on NPs and APPs moving from the traditional patient care to aesthetics?
Oh, that's an interesting question. I think there I've seen a big push in aesthetics over in LA when I used to work in Los Angeles. I do recall a few of my nursing friends whose main goal was just to go to school just so they could have a degree, not to learn anything else, but to only do aesthetics. So I think if you're really good at it and you're able to carve out a business with that, that's good for you. And I think it's important that if you are in the field as a nurse practitioner in aesthetics, that you also take into regards all other risks that come with it and be very, very transparent with the patients that you are treating. Because one of the things, even if you're in the aesthetics business, is to still look out for your patients and
Hmm.
protect the patients and advocate for them. So if a patient does come to you and you think that they're high risk for it or that they may not benefit from whatever procedure you want them to do, be very transparent so that you don't end up harming anybody. So do no harm was one of the nursing theories.
Do you see a lot of medical legal cases in the kind of nurse practitioner and APP community?
Not encountered any medical legal issues so far, but I'm someone who's known to be very, very protective in my documentation. You can hear my nurses always saying, "Oh, Sim's gonna say you're gonna get my license taken away for this reason, so let's not let's not do that." So I'm extremely cautious. I'm extremely careful about my document. I spend a lot of time on my notes, and I make sure that I address any abnormal lab value or encounters or concerns in my note, and then there's a plan highlighted. So knock on wood, haven't had any kind of medical legal issues so far, but of course, there are some that the other nurse practitioners have encountered. So I think I just try to protect myself with good documentation.
That's good. And you also, certainly just speaking with you, it sounds like someone who is very thorough, and very detailed. So I think that's obviously very important.
Mhm.
Um, just moving aside from the nurse practitioner role, I want to just talk to you about what you feel like the next steps for you would be. I know some nurse practitioners go on to get their doctorate. Some try to do some independent practice. Do you see yourself staying in academic?
Yes, my goal is to, once my kids are a little older and I have more time,
Hmm.
go back for my PhD in research. I've
Oh,
always
wow.
been a big, big fan of research. Currently, a PI and a sub-I on a bunch of different research studies that are ongoing at my current institution. So the goal would be to go back to school and get my doctorate. Not the doctorate of nursing practice, not the DNP, but the actual
PhD.
PhD in research. And then I love teaching. I love
Mhm.
having students, being a preceptor to students. So eventually, maybe teaching at one of the institutions part time as a clinical instructor or as an associate professor would be the next steps once my kids are a little older and I have more time. Yeah,
That's amazing.
thank
Well, thank
you.
you so much. Anything else that you want to add, Simran?
No, I think this was a great discussion. Thank you for having me on here. And I do see a very, very bright future for nurse practitioners. And I'm hoping that the colleagues that I get to work with in the future are well prepared and are in this profession for the right reason. Um, and keep patient outcomes and patient care as their main focus. So.
This is the first interview, but we hope to do more interviews with you in the future.
Yeah, thank you. Thank you so much for having me. This was great.
The one last thing I wanted to add is I think these conversations are important. I think oftentimes MDs and APPs don't realize we're on the same team, right? We have to work together
Yeah.
because out of everyone in the healthcare system, it's really just us who sees patients. Everyone else around us telling us how to practice, their role is a little different. And I think sometimes there is. How do I say it? Not a lot of collegiality. Sometimes they make it seem like we're pit against each other, and I don't think that's the case because especially in places where I've been, APPs add so much to patient care, and they are so helpful. And so I think moving forward, we really need to work together as MDs with our APP colleagues if we want to make any kind of measurable difference in the healthcare system.
Yeah, yeah, definitely. Luckily, I've been able to work with physicians who see us at par and not anybody who's like below them or anyone who's a little less than them. So I think I've been blessed to work with everyone who thinks of us as their colleagues and refer very complex patients to me. And I feel very honored when that happens, when they want me to follow the patient who's complex, who they think will be best suited to see me. So I think overall, it's been great.
Thanks for tuning in to Be Empowered, the podcast. If you enjoyed this conversation, don't forget to subscribe, leave a review, and share with someone who needs to hear this. Stay strong, stay empowered, and we'll see you next time.